housekeeping items to review. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, and the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters or regarding the technology, please type them in the Q&A pod on the right of your screen. We will address as many of your questions to the presenters as time permits during the discussion group following this webinar. We will also be conducting a poll and appreciate your participation. So when you see a poll pop up on your screen, please enter your responses. This webinar is being recorded and slides will be disseminated via the GAINS listserv following the webinar. We will also notify you when the webinar recording is posted to SAMHSA's YouTube channel. A certificate of attendance will be available for download at the end of the webinar. Please note this certificate is for personal portfolio use only and is not intended for CEU credits. There is American Sign Language interpretation for this event. The interpreters for today are Dave Gratzer and Marika Larson. To view American Sign Language interpretation, go to the layout in the upper right-hand corner of the screen, then select side by side for best visibility of the interpreters. There's also live captioning for this event. To view live captioning, select the Accept button in the Multimedia pod located in the lower right-hand corner of your WebEx screen. The color contrast of the live caption pod can be changed as needed. The high contrast style is recommended for best visibility. And next, I'd like to introduce today's webinar agenda. So coming up next will be Roxanne Castaneda, who will give some comments from SAMHSA in just a moment, and then followed by the presentations from Drs. Jessica Klaver and Gary Fudeback will follow. And now I'd like to turn this over to Roxanne Castaneda, who is the Public Health Advisor at the Substance Abuse Mental Health Services Administration for some opening remarks. Roxanne? You might be on mute, Roxanne.
Okay. Sorry about that.
That's okay.
Thank you, Michelle. Hello and welcome. I'm Roxanne Castaneda, the SAMHSA CMHS lead to the GAINS Center for Criminal Justice Projects and the lead for the Early Diversion Project. I want to take a moment to thank the GAINS Center, particularly Dana Brew, Michelle Saunders, and Sam Rogers for their excellent work at developing this event. In the Journal of Correctional Healthcare, there was an article about reentry of prison inmates with mental illness, obstacles, programs, and best practices, written by Esther Galletta et al. She describes forensic assertive community treatment, or Assertive Community Treatment Act, as a model developed in the early 1970s with the goal of integrating hospitalized individuals with severe mental illness into the community. This model has been successfully implemented across the United States since its inception. This intensive program focuses on maintaining its participants' psychological stability and maximizing their capacity for daily independent functioning without relying on the structure of any institutional setting. Its core components feature the following: multidisciplinary treatment teams, low patient-to-staff ratios, ideally 10 to 1 or less, home visits, around-the-clock patient access to staff, assertive outreach to reluctant patients, and individualized approaches to treatment needs. A particularly unique aspect of ACT is its time unlimited nature. That is, patients remain as participants in the program, sometimes for life, though their services may be tapered off to reflect their recovery. After decades of its successful application, the ACT model evolved to serve incarcerated individuals as well, and forensic assertive community treatment, or FACT, was born. FACT adjusts the focus of treatment to preventing future incarcerations and usually involves the patient's parole officer as a member of the multidisciplinary team. The parole officer undergoes mental health training prior to engaging in the program, which has been shown to increase agreement between officers and other members of the team when making decisions regarding the patient's treatment and/or potential disciplinary action. FACT has been implemented in various communities across the United States and has enjoyed general support for its efficacy from the research community. A 2010 study conducted in California found that participants in FACT were significantly, a study in 2010 study conducted in California found that participants in FACT were significantly less likely to be rearrested than their peers in a control group in both the first and second years following release. Other research has confirmed this pattern among participants of FACT programs implemented elsewhere. Another study revealed remarkably encouraging results with positive outcomes related to multiple domains, including non-reoffending, psychiatric stability, substance abuse abstinence, stable housing, and meaningful activity. Benefits of FACT programs often attributed to their success in reintegrating their participants into the community include collaboration with criminal justice systems and offering mental health services internally. We are looking forward to the presentation by today's experts. Michelle?
Thank you, Roxanne. We really appreciate you participating and providing those opening remarks. Today's presentation is part of the Gaines Center's 5-part virtual learning community on early diversion. And so we just wanted to point out the last 2 in our series. We want to kind of make sure you can be on the lookout for registration for both of these upcoming events in June and July. And now I'd like to introduce our 2 speakers for today's presentation. First, we have Dr. Jessica Claver, who is Senior Director of Behavioral Health Sciences at the Center for Alternative Sentencing and Employment Services, also known as CASES, in New York City. She is a clinical and forensic psychologist with more than 18 years of clinical, research, administrative, and teaching experience in behavioral health care settings. Prior to work for CASES, she worked for the New York State Office of Mental Health as a psychologist at Kirby Forensic Psychiatric Center and as the Chief of Mental Health Treatment Services at Bronx, New York Psychiatric Center. She holds a Bachelor's of Science degree in psychology from the University of Wisconsin-Madison and a PhD in clinical psychology from Simon Fraser University in Vancouver, British Columbia. She completed her pre-doctoral psychology internship in the forensic tracks at Bellevue Hospital, New York University. We are also joined by Dr. Gary Cuddyback, who is a distinguished professor and research fellow at the University of North Carolina at Chapel Hill. His research focuses on individuals with severe and persistent mental illnesses, especially those involved with the criminal justice and those who have chronic and disabling mental health and physical health conditions. He has conducted research on the physical health needs of persons with severe mental illnesses, the prevalence of individuals with severe mental illnesses in prisons and probation settings, and the role of Medicaid on mental health service use and recidivism after jail release. His research also includes the characteristics of persons with mental illnesses who are incarcerated in jails versus prisons, He has used large administrative data sets to develop methodologies for estimating the prevalence and service needs of severe and persistent mental illness in a community. He has published over 50 research papers and has been involved in dozens of projects focused on persons with severe mental illnesses. So you can see from our description of our two presenters that we have very knowledgeable and distinguished presenters for our topics today. So now, before we get started, I do want to let you all know what you look like in the audience, you know, who is joining us and where you're from. And so this comes from the poll you all took, so I want to thank you for taking a moment to do that. So it looks like that for today, we have about 53% of our audience is coming from an urban area, with 21% from rural and 20% from urban. And then looking at sort of the professional affiliations that you identified, let's see, our top affiliations is actually probation and parole, followed by community-based healthcare providers, public health providers. We have 26% from government. That's a great showing because the support of government is always so critical. And we have 7% from judiciary. So it looks like we've got a really good mix of individuals that work in different sectors of the community that are addressing issues around helping people with severe and persistent mental illnesses be able to live within their communities and stay on a journey of recovery. So it's nice to have all you here, and we want to thank you. So at this time, I'd like to turn the presentation over to Jessica, Dr. Claver, and she's going to begin the presentation.
Thank you, Michelle, and thank you to SAMHSA for inviting me to give this presentation this afternoon. Today, I'm going to be talking about forensic assertive community treatment, or FACT, in New York City. My goals today are first to describe the FACT model as it works in New York City, and also to describe how FACT services can be part of an early diversion response for individuals with serious mental illness who have criminal legal system involvement. So first, just a little bit about the organization I work for, CASES. Our mission is to increase public safety through innovative services that reduce crime and incarceration, improve behavioral health, promote recovery and rehabilitation, and create opportunities for success in the community. In addition to our behavioral health division, we have a clinical and community alternatives department, which is our adult alternative to incarceration programs, an education, career, and enrichment department, which serves our youth and emerging adults, and also a pretrial services department, which is a bail diversion program in the city. At CASES, we currently have over 30 programs operating out of offices in 4 of the boroughs, and we serve over 7,500 youth and adults annually. So to ground us in assertive community treatment, or ACT, ACT is an evidence-based practice model that's designed to provide treatment as well as rehabilitation and support services to individuals who are diagnosed with a serious mental illness and whose needs have not been well met by more traditional mental health services. So an ACT team is a multidisciplinary team. There are usually about 10 or so staff on an ACT team. We'll go through them in a little more detail later. In New York State, each ACT team serves 68 clients, maximum at any given time. And really the heart of the ACT model is a daily morning meeting where every member of the team meets every single morning and discusses every client on the team. So this happens before people go out into the field each day. ACT is highly individualized, comprehensive, and flexible. So our treatment plan goals are, you're going to see them in the exact words of our clients, so we can help them achieve their own person-centered goals. ACT is also really comprehensive and holistic. So we try to do everything for the person within the ACT team, unless they need to be referred out for a specific service. ACT clients receive 6 at least services per month in the community. So this is a really important part of the model. We go to where you are, wherever that might be. There's also 24/7 crisis coverage. This is mostly by phone. And I'll talk a little bit more about this later related to diversion. We also have wraparound funds in New York State for our ACT teams, usually about $500 per client per year, approximately. And these service dollars are really essential for the early engagement process, helping people with their basic needs, and also encouraging people towards their treatment goals. So in New York State, the average length of stay on an ACT team is about 2.5 years. It's about the same actually in the city as it is across the state, as it is for the FACT teams so far, which is interesting. And in New York State, there are, by my last count, 109 ACT teams in New York, 64 of which are in New York City. And so we like ACT in New York. And one reason is because of the positive outcomes that we heard a little bit about, including a decreased number of psychiatric hospitalizations and length of stay during those hospitalizations, and also increased housing stability. So in October 2016, New York City launched 5 forensic ACT teams, and Cases actually runs 3 of these 5 teams. So how does one get onto a FACT team? So I'll go over the admission criteria. First is the basic ACT admission criteria. So adults who have a serious mental illness, this is usually schizophrenia, schizoaffective disorder, bipolar disorder, and whose needs have not been well met by traditional approaches. So for example, an outpatient mental health clinic. This is usually demonstrated by a person having sort of frequent psychiatric ER visits or psychiatric admissions. And a FACT client also has recent or current involvement in the criminal legal system, usually in the past 12 months, that's related to their mental illness or related to non-adherence with treatment. In New York City, all ACT referrals go through the single point of access, which is operated by the city's Department of Health and Mental Hygiene. So any provider or any person really can refer someone to ACT in New York City, but all the referrals go through the SPOA. And there is some priority for people who are on assisted outpatient treatment orders or AOT orders. These are civil court orders for committing people to outpatient treatment. So I'm just going to go over the way forensic ACT teams are staffed in New York City. So this graphic shows kind of the core staffing of a basic ACT team and also the forensic ACT staff enhancements. So every ACT team is going to have a team leader, a psychiatrist or a psychiatric nurse practitioner, nursing staff, a program assistant, a wellness specialist, 2 substance use specialists, a family specialist, an employment specialist, and usually a peer specialist. So that's kind of the core staffing. And what FACT adds is a second peer specialist. And this is usually someone who has lived experience in the criminal legal system, a dedicated housing specialist, and also a key role that we call the criminal justice specialist, who's really in charge of helping the clients navigate their legal situations. Our FACT staff go through a lot of training in New York City. So all ACT staff in New York State go through a basic set of training through the ACT Institute, which is part of the Center for Practice Innovations at Columbia University's Psychiatry Department. And FACT staff do kind of two sets of extra trainings. First is a certificate series through the Academy for Justice Informed Practice. This is a workforce training initiative that's housed at a local nonprofit in the city, where they really learn a lot more about the criminal legal system, about recidivism, violence, and even some first-person perspectives from people who've been through the system themselves. Our FACT staff are also trained to administer two risk assessment measures. Right now, they're doing the LSCMI for criminogenic risk and the HCR20 for violence risk. So in terms of ACT and FACT services, on the left here, I have the core ACT services that are provided to every ACT client in New York. So as you can see, I won't go through them all, but there's a variety of psychiatric, rehabilitation, and support services that every ACT client gets. And on a forensic ACT team, I think clients are going to get some specialized or enhanced services. Really more of an expanded legal history assessment. So we might go through someone's rap sheet and really kind of ask them about their experiences in the criminal legal system. As I mentioned, we're going to have some specialized risk assessments that are going to get integrated into our treatment plans. We do warm handoffs with our legal providers. So we often get clients who are coming out of jail or prison, who may have been in for a long time, and we will pick them up right when they're getting released. And we do that reentry work, which is really a critical time for our clients as we're welcoming them home and engaging them in FACT services. If they go back into jail, we'll keep continuity of care while they're incarcerated, do a lot of advocacy for them, maybe to be released back to our program. And really all of this with a kind of a special trauma-informed lens, I think, really training our staff to think about our clients' experiences of arrest, of incarceration, and how those traumas might be impacting them. And finally, FACT is going to have an explicit focus on legal outcomes. So ACT is, of course, going to be focused on psychiatric, psychosocial outcomes, but a FACT team is really going to be thinking about preventing a rearrest or a reincarceration. So in order to do this work, we have a variety of partnerships in the city, the Department of Corrections with our local Rikers Island Jail, the Department of Probation, the State Department of Corrections and Community Supervision. So this is state prisons and also parole. In the courts, we have contact with judges, a lot of contact with defense attorneys and also prosecutors, and supporting our clients if they're in alternative to incarceration programs, for example, mental health courts. So I'll talk a little bit about how FACT is funded in New York State. This is probably one of the most common questions I get. In New York, ACT is a Medicaid service. So we bill Medicaid for our 68 clients. And so if we provide 6 or more contacts in the month, we can bill at what's called the intensive or the full rate to Medicaid. If we see the person 2 to 5 times a month, we can bill at a partial Medicaid rate. We also bill this rate if they're in the hospital, but we're able to maintain contact with them. So as you can see, if we don't see them at all, or we see them one time, or if they don't have Medicaid turned on, we are unable to bill. In New York, our Medicaid system went under transition in October 2015 into managed care, which changed operations a little bit on ACT. Primarily, we have a lot more contact with people's insurance companies and getting authorization for continued ACT services. The FACT teams in New York City receive some deficit funding from the city. It's around $650,000 per team per year. And this recognizes that, our clients, we're not always going to be able to bill Medicaid for our clients. Sometimes they go back in and out of jail settings or other institutional settings. So there is some funding to supplement the Medicaid income. We do also have one other ACT team at Cases that functions as an alternative to incarceration program. And that team specifically receives a little bit of blended grant funding. All right, I'm just going to transition here to talk a little bit more specifically about Forensic ACT and early diversion in New York City. So just to ground us here, I have the sequential intercept model, thanks to SAMHSA, which shows us all the different sort of opportunities that we have to intervene. If we have someone with serious mental illness who could potentially become involved in the criminal legal system or further entrenched in that system, there are quite a few opportunities for a FACT team to directly assist the person or to work with other city programs with the same goal. So I'm going to go through just a couple of the intercepts and talk about some examples of how FACT can help an individual or partner to help in an early diversion response. So in the early intercepts, this is in community services, law enforcement. I think it's really key that the Forensic ACT model has the 24/7 crisis phone. So this is an excellent opportunity for diversion, sometimes from a hospitalization, sometimes maybe from an arrest. So ACT clients can call this phone any time of day. It rotates amongst the staff. And we're almost always able to de-escalate situations, provide support, and really divert people from further systems involvement. We also have partnerships with other city field-based behavioral health crisis services. And so this is an increasingly robust system in New York City. So I thought I would just mention a couple of them. The first two are really kind of quite brief crisis services. So they're not a replacement for 911, but they can be accessed through a city hotline, 888 NYC WELL, or through our 311 information system. The first, mobile crisis teams. These teams respond to people who are experiencing a behavioral health crisis and who are unable or maybe unwilling to engage in care. So as you can imagine, they get a lot of calls from family members. The mobile crisis teams are staffed by a mixture of mental health clinicians and peers, and they provide crisis intervention, de-escalation, assessment, and linkage to ongoing care. They operate from 8 a.m. to 8 p.m. 7 days a week, and they can respond usually, I think the aim is in about 2 hours of a referral. So as you can see, they have a little more capacity for kind of an immediate crisis response than a FACT team might, so we might engage mobile crisis. They might make 1, 2, 3 contacts with someone maybe over a couple of weeks to help them. The homeless outreach teams in New York City, they engage people who are street or subway homeless, who often have behavioral health concerns. The goal is to kind of encourage them to move into housing. So they offer immediate assistance, transportation to a shelter, and ongoing case management. They can also assess for kind of medical, mental health crises that might require a 911 response. The second two crisis services are a shorter term. not long-term like a FACT team, but a little longer than the first two. The first is what we call co-response teams. These teams offer crisis support to people with behavioral health challenges who have been assessed to be at an elevated risk of harm to themselves or others. So a co-response team is kind of unique. It has a behavioral health professional and 2 NYPD officers. And the co-response team provides engagement, assessment, de-escalation, supportive counseling, and referrals to services. They usually respond in about 24 hours, and they can kind of stay with someone for maybe up to 90 days. So a FACT team might engage a co-response team, for example, if a client is missing, we can't find them, and we think there might be some kind of significant risk issue happening. And finally, the health engagement and assessment teams, or the HEAT teams. In the city, they offer crisis support for people with behavioral health or general health concerns that are really impacting their functioning. The HEAT team has behavioral health professionals and health navigators who are essentially peer specialists who have lived experience. And they also provide engagement, the peer support component, assessment, de-escalation, and service referrals. And similarly, they do respond in 24 hours and can see someone for up to 90 days. I will just note just around interaction with between FACT and law enforcement. You know, sometimes our teams do have to activate 911 for a client. Or we're at the scene where 911 is being activated, maybe by a housing provider. And so in the city, the NYPD arrives first, and then EMS comes sometime after that. So that is one opportunity for us to really explain the person's situation to the police and advocate for a mental health response, you know, taking the person to a psychiatric ER instead of central booking. We've also kind of more recently had direct interactions with law enforcement. You know, our clients carry our phone numbers around in their pockets, and if they have an interaction with the police, they might actually pull those numbers out. So we sometimes get direct calls from an NYPD officer, you know, who's encountered our client on the street, and we're able to speak with them and really advocate for our clients at that point, which has been kind of interesting. All right, it's a middle intercept. So if people do kind of go into the system, I think this is really about coordinating care and advocacy. And here the role of our criminal justice specialists on the FACT team is really key. So as I mentioned, we are also a pretrial services agency. So if one of our FACT clients shows up in the system, in the pretrial system, they can contact us immediately. We're sometimes able to arrange for diversion, even at the pre-arraignment level, which is great. If our clients do go into jail, we call the medical unit, let them know the history, the medication, and kind of start coordinating care, and really push to be part of the discharge plan. And I think it's essential to note that we continue to provide FACT services while someone's incarcerated. I think sometimes if an outpatient mental health consumer goes to jail, they might get discharged from a program, or they might just kind of wait and see if they come back. But we're very assertive about being involved when people are incarcerated. In terms of advocacy, we really help people prepare for court, advocate for their release back to the program, advocate for specialty mental health courts. And we find that connection to intensive mental health treatment is really valued by the courts. We can help them understand, for example, the reasons why someone might be missing court dates. Sometimes the courts will let us send compliance letters saying that they're still meeting with us 6 times a month in lieu of appearances at court. And, this might avoid a bench warrant or someone going back into jail if they're truly still engaged with the ACT team. And finally, I just want to mention some of the later intercepts. We actually get most of our clients at Intercept 4 coming out of prison or jail onto a forensic act team. And so I think FACT is uniquely positioned to help during this critical time. I had mentioned those wraparound funds to help people meet their basic needs, food, clothing. We can help people immediately with shelter, if they have any medical needs, the legal needs that we've discussed, their entitlements, vital documents, and of course, behavioral and medical needs. We can give people Metro cards to come see us or to get to their other appointments. It's amazing how a simple Metro card can prevent someone from immediately getting rearrested for jumping the turnstile to go do their parole report. And we really can help people navigate systems as well. And this is where the peer specialists are key. You know, people are involved in so many systems, from the legal systems to the mental health systems, the shelter systems, not to mention the systems that they want to be part of, like their family systems and the employment system. So I'll just end talking a little bit about parole and probation. Specifically with parole, our FACT teams do a lot of work with parole. And I think this is really about kind of getting on the same page. We try to work together, so FACT services are outlined in the parole conditions, and someone's success on parole is kind of part of their FACT treatment plan. And it's really best when parole is a partner in treatment, part of the treatment team. And this takes a lot of relationship building. You know, a mental health treatment provider and a parole officer don't always see things the same way. That's totally fine. And, you know, one example is maybe failure to report to parole. We have the opportunity to educate parole about serious mental illness. Sometimes our forensic act visits can count as a parole report. Another example I can think of is around substance use, which is an issue for a lot of our clients. And, you know, is it a behavior problem? Is it a health problem? We may see things a little bit differently, but we can really support a referral to detox or to rehab instead of a violation for a clinical relapse. And really, this is kind of like, again, around avoiding violations and further entrenchment. And we do find that our FACT clients on parole and are much more likely to sort of get another chance when we're involved. So thank you, and that is it for me.
Thank you, Dr. Claver. And now I'd like to turn things over to Dr. Cuddyback for his presentation.
Terrific. Okay, let's see. There we go. So I also would like to thank SAMHSA for the opportunity to speak this afternoon. And I think what I'll talk about is a nice complement to what you saw from Dr. Claver, and two parts to my presentation, really. The first, I'll talk about the complex needs of justice-involved individuals with severe mental illness, and then give an overview of where the research literature, the published literature, is at regarding forensic assertive community treatment. So if you think about our public mental health system, it really has shrunk in the last 50 years, where folks with severe mental illness typically resided in large state mental health hospitals, where, if you think about it, care and treatment were together, right? But now that folks are diffused out into the community, care and treatment are separate, and individuals with severe mental illness need to navigate different systems, one for housing, one for substance use treatment, another for physical health care, another for entitlement programs, which makes it very difficult. Criminal justice system, unfortunately, is a new frontier for service provision. So if we want to provide services for folks with severe mental illness, the justice system is often where we go to do that. The fates of individuals with severe and persistent mental illness are often closely intertwined with criminal justice policies. So if you tweak city ordinances around panhandling or trespassing or what have you, it's usually those who are most vulnerable and marginalized who are impacted first. And also, the criminal justice system really functions as a place of last resort for individuals with severe and persistent mental illness to a large extent, unfortunately, and also as a public health outpost. The point here being that sometimes the justice system is someone with severe and persistent mental illnesses' first and best chance to get diagnosed, either with a mental illness or a physical health problem. Okay. So on any given day across our country in our network of state hospitals, there's about 37,000 individuals with severe and persistent mental illness. Juxtapose that with over 250,000 in prisons, over 130,000 on any given day in our 3,400 jails across the country, and almost 1.5 million on probation or parole arrangements. So clearly there's a lot of individuals with severe and persistent mental illnesses across the spectrum of the criminal justice system. So individuals with severe mental illness generally have complex needs, and some of the cases I've made in the research I've done is once you layer on the justice involvement, they become more complex, more difficult to serve. You've got issues around homelessness that are exacerbated, stigma, social isolation, substance use, poor physical health, and so forth. So you layer on the justice involvement, and things become more complex and more difficult. So here's a case in point, comparing a few health disorders among the general population of individuals, those with SMI, which is the green bar here, and justice involved SMI, the red bar. You can see across, at least with these 4 disease categories, when you layer on that justice involvement, from a physical health standpoint, these individuals are a sicker population, more infectious diseases, more blood disorders, more skin disorders. And if you think about this from both a mental health perspective and a public health perspective, individuals running around with disorders such as these not being treated can create a lot of issues. Similarly, when you layer on justice involvement, and the green bar here are individuals with severe mental illness with no justice involvement, and the red bar are those individuals with criminal justice involvement, you can see it's sort of a harder core clinical profile. So more likely to have schizophrenia or schizoaffective disorder, more likely to have antisocial personality tendencies, more likely to have histories of homelessness, and more likely to have a history of substance use or active substance use. So as you think from a clinical perspective, providing fact services, where are the target areas for intervention? And then trauma. Cumulative trauma is something I've been focusing on for the last couple of years, and this is a sample of probationers with severe and persistent mental illnesses who either have schizophrenia, bipolar disorder, major depression. And first, the blue bar is the total sample at 204. The red bar, the portion of that sample that met diagnostic criteria for post-traumatic stress disorder. And as you can see, half of the sample of young probationers with severe mental illness met diagnostic criteria. So think about this clinically from a criminal justice perspective. Think about, trauma-informed approach to probation or parole. And then what you see on this slide lists the type of interpersonal traumas experienced over the lifetime of these individuals. So looking at the blue bar, which is the total sample, 80% experienced a physical assault, 60% experienced an assault with a weapon, over 50%, right around 50% experienced a sexual assault, and then almost 40% had a life-threatening illness or injury. 90% of the sample experienced one of these interpersonal traumatic events. So certainly a clinical issue and an issue for both mental health and criminal justice services. And then basic needs. Again, the same sample of 200 probationers with severe mental illness. And as we all know, probation comes along with requirements that need to be met. Getting safe and adequate housing, maybe getting a GED, going to group treatment, adhering to and complying with treatment and court recommendations. But what you'll see here is among the sample, 60% had unmet basic needs, food, clothing, shelter. 60% needed medical care. Almost 70% had dental care. Matter of fact, I believe I read one of the top 3 reasons, just in the general population, for emergency department visits is dental pain. Over 60% needed outpatient mental health services, and over 70% needed medication. So lots of needs among this justice-involved group with severe mental illness. Similarly, almost 80% did not have a valid driver's license. And then lots of transients, as we all know, people couch surfing or homeless. Um, uh, just over 60% of these probationers with severe mental illness had Medicaid, which, as we all know, is the gateway to accessing outpatient mental health services in particular. And a number of these folks had a prior criminal justice history. So again, painting the profile of the additional complexities when you layer on justice involvement with severe and persistent mental illness. So I won't go into this sequential intercept model because we just talked about it, but if you think about it, a lot of our interventions are focused on connecting justice-involved persons with SMI back into mental health services. We all know there's lots of reasons to get into the criminal justice system or be justice involved that have nothing to do with mental health. But yet a lot of our interventions for this population are focused on reconnecting individuals to mental health, specialty mental health courts, reentry programs, specialty mental health probation, and so forth. But what if it's more than just mental health services and more about mental health treatment? And here are the criminogenic risks that Dr. Klaber mentioned listed here. And is there a synergy between mental health and criminogenic risks? And as a mental health treatment community, do we address these as well as we do mental health needs for those who are justice involved? And you'll notice, of course, mental health or mental illness is not a criminogenic risk. So if you look at, these are data from probationers across the state here in North Carolina. Green bar are individuals on probation who do not have severe mental illness, and the red bar are those who do. And you can see across the board with respect to these criminogenic risks, there is elevated levels of each of these criminogenic risks. So substance use, antisocial personality traits, kind of a dysfunctional family history, impulsivity and self-control, and antisocial values. So when you're addressing criminogenic risks among individuals with SPMI, where do you target with your cognitive behavioral treatments? And similarly for prison, I won't spend any time on this slide, but these patterns are the same for individuals with SMI who are in prison. Also, individuals in prison with severe mental illness are more likely to have infractions, more likely to spend time in administrative segregation or isolation. Okay, so forensic assertive community treatment with respect to the literature. So what do we know? What do we need to know with respect to the published literature? So these are results from a comprehensive literature review that I did recently, and then I'll just talk about some of the broad themes here, and then I'll wrap up. Oops, don't want to go backwards. So in terms of fact eligibility, ACT eligibility standards are clearly established, and you start with SPMI, so a severe and persistent mental illness, typically defined by a diagnosis, duration, and disability. And then you add on some level of hospital use, so 2 or more hospitalizations in a calendar year, or 6 months or longer in a state hospital is typically the threshold for ACT eligibility. There's not consensus with respect to the literature I reviewed about fact eligibility. So there's agreement about severe and persistent mental illness, but there is variability in definition of justice involvement. So is it 2 jail admissions in a calendar year? Is it the fact that you're on probation? Is it a release from a jail, a release from prison? The thing about ACT eligibility is we do know that ACT is most effective and most cost effective for those who have high hospital use. we have yet to really determine those thresholds for fact. So lack of sort of standardization of fact eligibility. All right. There we go. Fact staffing, and you heard quite a bit about the cases team, which I thought was terrific and really laid out nicely the additional staff that comes along with a fact team. So certainly the special experiences and skills related to justice involvement, focusing on substance use, trauma, being motivational, being authentic, using a non-judgmental approach, and certainly appreciating the power differential and the maybe even the institutionalization that occurs with lengthy jail or prison stays, and being able to address those complex needs. So what you saw in the presentation earlier, so having that criminal justice specialty is something that sets fact apart from act, certainly. And it might be one of those things where if an ACT team is occasionally serving someone with justice involvement, although I don't know how typical that is anymore, maybe the opportunity to get good at interfacing with the justice system is not as well expedited as if you're only serving justice involved individuals and constantly working with agents of the criminal justice system. All right, so fact models, is it just adding to the elements, the standard elements of assertive community treatment? So in the literature, there were lots of variability in what fact models look like. Some included a residential substance abuse that was almost mandatory prior to release from jail and prison. Are probation or parole officers integrated with the team? Do they attend those daily team meetings that Dr. Klaber was referring to, or are they kept at a distance? And one issue around here that appears in the literature is the possible sacrifice of therapeutic trust and rapport by having probation or parole directly on the team. Counter to that, though, having probation or parole on a team gives a little more teeth and leverage, if you will, to enforcing probation requirements, enforcing other aspects of treatment, especially if it's mandated. And then criminogenic risks. So you saw a good example here with the cases team with respect to how that fact team is addressing criminogenic risk. But with respect to the literature, that's not standardized across the board. Many ACT teams, many fact teams won't be addressing those criminogenic risks maybe as thoughtfully as you saw earlier today. And also fidelity. Now there is a recent article by Steve Lamberti and Rob Weissman out of Rochester that I believe is coming out soon that introduces a fidelity measure for forensic assertive community treatment team. But up until now, we really haven't had one. Where do you locate your FACT team? Is it a jail or prison reentry team? Is it associated with specialty mental health probation? Is it freestanding? Is it connected to a mental health court, for example? So there's variability in the literature with respect to where these teams are located. And you've heard quite a bit about financing and sustaining FACT. A lot of these teams are Medicaid dependent, which comes with its own set of rules and regulations and challenges. For example, given the complexity, once you layer on the justice involvement and maybe you add in antisocial personality traits, which makes individuals harder to engage, harder to build trust with, harder to serve. Someone coming out of jail or prison like that with no benefits, there's almost a perverse incentive not to pursue them if they're not Medicaid, don't have Medicaid benefits at that time. So, teams that are relying on Medicaid can only spend so much time trying to engage folks who are not Medicaid enrolled, which is a lot of the population we're talking about here. So other funding streams, county funds, state funds, blended funds in that fashion, are always good with respect to filling in the gaps for those who are not funded by Medicaid or other insurance programs. All right, and outcomes. Yes, there is some evidence there. There's improved recidivism, which think about that is an individual behavior on the part of individual with severe mental illness, and there seems to be some reduction in technical violations. This is really a system or an officer, probation officer behavior. So maybe integrating an officer with a FACT team helps with some negotiation, like let's rethink, rather than sending Gary back to jail, maybe we can try another treatment alternative or so forth. And then there, as Dr. Klaber mentioned, improved mental health and substance use functioning there. All right, so one thing to ask yourself when we talk about any evidence-based practice is for whom, under what circumstances, and with what outcomes. So it seems like most teams are starting with the structure of assertive community treatment, and then FACT teams are scaling up or down with enhanced clinical competencies and components, addressing substance use, physical health, housing, and then some sort of collaboration with the criminal justice system, whether that's a parole or probation officer on the team or outside of the team. Willingness to engage people who are difficult to engage, flexible financing to allow for prolonged outreach and service, particularly to non-Medicaid and non-insured clients. And then one thing to think about as both the mental health and criminal justice communities. So how can resources be shared between mental health and criminal justice partners to better align who benefits and who pays? So for example, community mental health might be paying for FACT, but it really is the justice system that benefits from maybe me being in the local jail fewer times this calendar year than the last time. Same with ACT. There was an early article about ACT, which, as we heard earlier, has been around since the 70s. But if you think about ACT and its job to keep folks out of the hospital, well, that benefits the hospitals, but the community mental health system is paying for those services. Okay. So also, we can't forget our social determinants of health, and you can substitute social determinants of justice involvement. And I have this horribly oversimplified way of talking about what everybody needs, particularly those with severe mental illness, to stay out of the criminal justice system in their community. Everybody needs a bed, a buddy, and a job, right? So, and FACT teams and ACT teams are great at connecting individuals with severe mental illness to these supports. How can barriers introduced by justice involvement be relieved so folks can access safe and adequate housing, affordable housing, supported employment options, and also finding folks pro-social support? Okay, so on the dot, 3 o'clock. So I will turn it over to my colleagues at SAMHSA.
Thank you, Dr. Cuddyback. That was very, very informative. So I am going to advance the slide. Okay, so we will shortly move into the discussion group portion of today's event and have some time to address several of the questions that came in. And I was watching the questions, and they're really good questions. So if you haven't had a chance already, type a question in. Please do so in the QA pod to the right of your screen. Just to let you know, accompanying this webinar, we've made available a brief on forensic assertive community treatment, FACT, and you can find it for download on the SAMHSA website at store.samhsa.gov, and you can also download it in the file transfer box that should be appearing on your screen. Okay, again, we want to remind you there is a webinar attendance certificate. If you're interested in downloading that for personal use, you can do so. And you should see a file transfer box pop up, and under the file name, click on the files you want, and it should turn blue, and then download button should turn a darker gray. When you click the download button, it should initiate the process to download the certificate directly to your computer. So if you don't see the file transfer box, or you have any difficulty with this, please email Sam Rogers at srogers@prainc.com, to request a copy, and Sam will have his email in the Q&A box for those of you to copy it if you need to. So we want to also let you know about an upcoming webinar hosted by SAMHSA's Gain Center. On June 2nd from 2:30 to 4 Eastern Time, there is a webinar on evidence-based treatments for trauma in veterans. Registration information for these webinars will be shared via the Gains listserv, so please keep your eye out for that information, and we hope you can join us. If you are not already signed up for the Gains listserv, then I encourage you to sign up. Here's the link on the screen. You just enter that link into your favorite web browser, and it'll take you to a place to enter your information. And you can make sure that you stay up to date with all the Gain Center's activities. And again, we'd like to thank you for participating in today's event. If you have any other questions or comments, the Gain Center's direct contact is here on the screen on the website. And so you can go to samhsa.gov/gains-center, or you can use the phone number to directly reach us. So now, if you'd like to stick around for the discussion group on today's webinar, we encourage you to do so, because this will allow you to not only get some response to your questions, but hear from the other participants what their questions are, and to allow our presenters to drill down a little bit more in these areas. So just stay with us, and we are now going to move directly into the discussion group. And I think Dr. Claver and Dr. Cuddyback will join us back on the screen, so we can talk with them directly. So first of all, I want to thank you. That was very, very informative. I really felt like the research part, Dr. Cuddyback, really gave a lot of the perspective about needs and how to focus interventions, focus services, particularly when using a fact team model. And Dr. Claver, I think you laying out what a fact team model looks like, and then how it is operationalized and funded, I think gives our audience a chance to really think about this model for their own community. So again, I want to thank you for that. We have several questions, so I'm going to get started, and really they could be answered by either one of you. So you might both share a question if you both have something you'd like to say. But let me maybe start this one with you, Dr. Claver. So this person asked, when you indicated the number of visits that a fact team makes, you said the question is that 6+ community visits per month is far less than high fidelity ACT. Do you find this reduced contact works better for this specific forensic population? And I don't, yeah, you're not on mute.
Thank you for that question. So the number of contacts per month that are required in New York is actually the same for ACT and for FACT. So it's an interesting question. Does a FACT client need 6, much more than 6, maybe less than 6? And so, as you notice in my presentation, the number of times we see someone per month is directly linked to the Medicaid reimbursement for the team. So I think that's part of it, that we are doing our 6 visits with them. I will say that the FACT model is, like ACT, is designed to be quite flexible. So I think there are times that a particular client for a clinical reason might be seen many more times per month than 6. And similarly on the other end, if we're transitioning someone maybe to an outpatient clinic, we might actually be seeing them fewer times than 6. So we are finding clinically that I think this number of visits is feeling sufficient, but certainly it's an empirical question and a good one.
Okay, thank you. What kind of documentation of mental illness and non-adherence with treatment does a person need to have in order to be eligible? and that might go to Dr. Claver or even Dr. Cuttyback.
Yeah, go ahead, Jessica.
Yeah, so I'll start and feel free to add on. So in terms of documentation of mental illness, this sometimes comes from the facility that the person is in before the FACT team receives them. So a lot of times it's a hospital. Sometimes it's a state prison or a jail setting. We actually in New York State have access to a system called Psyches that's essentially a Medicaid claims data warehouse. So we're actually able to get quite a bit of information on intake in terms of someone's mental health history. And in terms of non-adherence with treatment, I think that the main way this is demonstrated is really through hospital use. So psychiatric ER visits and psychiatric hospitalizations traditionally.
Yeah, I don't have much to add to that, other there might be just local variability. Could be driven by how FACT is funded and if there are requirements, eligibility requirements connected to that funding, or just case-by-case decision made by these teams.
Great, thank you. So do we have, or is there data that shows a more robust impact from fact over act vis-a-vis a return to confinement for individuals served? So basically, if somebody, is in a fact team or in an act team and has criminal justice involvement, are we seeing any difference between, does a fact team do a better job at keeping someone from returning, or does an act team, or is there been any research around sort of the differences or differentiating that?
I can start with that one, but Jessica, please add. So I'm not aware of any head-to-head act versus fact comparisons in the literature. Now, there are articles years ago that came out that suggested assertive community treatment wasn't that effective at keeping folks out of the jail, but it also wasn't their primary outcome. As Dr. Claver mentioned, ACT was initially designed to keep folks out of the hospital, right? And that's what clinical services were focused on. So the studies that are out there that focus on fact, it's typically fact versus case management or other services, which those articles do show that fact is superior to keeping individuals out of the justice system. Some might say that any good ACT team should be able to keep someone out of the criminal justice system, although I think others would disagree. And as you've heard today, there might be special skills, special staffing, special competencies that might do a little bit better job than an ACT team that's only occasionally focused on justice-involved individuals. But let me turn it over, Jessica, to you for your thoughts too.
Thanks, Gary. I just have one thought to add, given that our agency has FACT teams and regular ACT teams. So we don't have any head-to-head comparison either. But I can say that one benefit of having the FACT teams is some of those skills and competencies sort of spread, into the entire department. And I think the best practices that the FACT staff are doing with people who are involved in the criminal legal system are then shared with our regular ACT teams, and to some extent they can also implement those practices. They don't have the enhanced staffing, but I think in many ways they can, for example, do the coordination when people are incarcerated, support them through their legal processes, at least at a basic level. So I think there is some some competency that gets generalized, which is helpful.
Great, thank you. So that leads to another question sort of in the line when you talked about sort of the enhanced specialties of staff. One of our participants was interested to know what type of discipline is used for a criminal justice specialist. I think you identified that as part of a member of the team. So what sort of discipline is that position?
Yeah, so I can speak to that. So the city mandates that that discipline is a licensed master's level clinician. So typically a social worker or a mental health counselor in New York City. I will say, however, though, that I think that this is really a competency-based position, and that that it could potentially, the role could be filled, I think, by someone who is very experienced, especially in navigating complicated cross systems issues, including the criminal legal system. Ironically, it's often our peers who have an extremely high level of experience and expertise in navigating these systems. So we are required to have a certain qualification, but I just want to put out there that I think that it could potentially be broader.
Great, thank you. So what are some of the key indicators of success for a FACT team? What are some of the key indicators that get looked at to say, is this successful?
Go ahead. Well, I'll say, assertive community treatment in all its history and all the studies, there's been over 50 randomized controlled trials of assertive community treatment. And even ACT doesn't keep all of the people out of the hospital all of the time. So if you think about what kind of outcomes should we expect from forensic assertive community treatment, and again, it comes back to for whom, under what circumstances, with what outcomes. If you're targeting individuals, who are most profoundly ill, who have the most profound justice involvement in histories, although there's no metric or threshold to it, but certainly a reduction in jail admissions, jail days, would be probably outcomes that we would expect from FACT. But having said that, let me turn it over, Jessica, to you and the kind of outcomes that your teams are looking towards.
Yeah, I think that's helpful. I just want to echo the idea of community tenure, and whether that's staying out of the hospital more than you did before, or staying out of jail more than you did before. I think on the ground too, potential other indicators would be, fewer parole violations, for example, than potentially a comparison group. And I think, just to go back to the basics too, engagement. So it's a different population. A lot of similarities to the traditional ACT population, but it is quite different. We see a lot of comorbid substance use disorders, a lot of comorbid personality disorders. And so just being able to engage a FACT population without sort of losing them right away, lost to services, I think is important to think about too.
So that gives a nice segue into this question when talking about engagement. So what do you find are some effective engagement strategies for FACT recipients, how to engage them?
Oh.
I'm in the ivory tower, Jessica, so
I'll start here.
You've got that one.
So I think first and foremost, engagement needs to be extremely client-centered. And so I talked a little bit about re-entry. And so it's interesting, if someone's coming out of jail or prison, we're ready to provide them all the behavioral health treatments that we feel like they need, but their priorities might be a little different. And so I think having an understanding during that critical time of intervention, when someone is really coming home, to understand about their basic needs. you know, people are very interested in having food, having clothing, having a basic way to get around, having, you know, some kind of roof over their head. And I think if you can meet people where they are, you're much more likely to kind of help them engage in the full fact model. So if you sort of come at them with the components of the model that you know, are important, you know, medicine, psychiatry, they may just have different priorities. And I think that, you know, neither one is not important, but we really need to meet people where they are. And again, I'm going to plug the peer specialists on ACT teams and FACT teams are really, really the ones kind of on the ground doing the engagement work. So someone who could say, you know, I've been there too. Like, you know, I was at Rikers Island 5 years ago, or, you know, I was on parole once and I got through it, you know, and you can too, and I'm going to help you with that. I think is just is extremely powerful.
Great, thank you. So I'm not quite sure how I want to word this, but as I was thinking and as I'm looking at these various questions, you know, Dr. Cuddyback, I was struck by the statistics that related to the physical health of individuals with serious mental illnesses that are justice involved, and you know, talking again about key indicators of success, reducing the amount of time someone may be in jail or jail days, etc. I guess I'm thinking about a twofold question. One is, do you also look at indicators in terms of impacting the physical health, since these individuals do have some pretty serious physical health that oftentimes has been neglected over the years, and they might not have had the resources and the connections to get their physical health? We also know that research has shown that people with serious mental illnesses potentially die earlier than somebody without a serious mental illness. So again, knowing that individuals may be on a FACT team for life, are we looking at, and again, it may, you know, this is sort of longitudinal, but kind of looking at the success of FACT teams, or the value of FACT teams, you know, also really focusing on improvement in one's physical health versus sort of not just keeping them out of jail or keeping them connected to their doctor and, you know, keeping them with a roof over their head, but, you know, again, looking at sort of that whole physical health side.
That's a great question. And it'd be interesting, Jessica, to hear some about what your team does. I will speak to what's in the literature. And first, even the literature focused on physical health outcomes and assertive community treatment is fairly thin. There haven't been a lot of studies that looked at the physical health outcomes of ACT consumers, even though you're right. They have, you know, diabetes at the rate of 3 or 4 times greater than the general population, and cardiovascular issues and obesity, metabolic syndrome. So very sick population. And I don't know of any studies that have looked at the physical health outcomes of FACT recipients. But certainly there's been, over the last decade or a little longer, a more concerted effort to integrate physical healthcare services and assertive community treatment. I haven't seen, although this doesn't mean it's not happening, but I haven't seen the FACT literature catch up there. But as I said, let me turn it over to Jessica to talk maybe about her experiences with her teams.
Yeah, thanks, Gary. I will say, just from a systems perspective, we do know in New York at least, and I imagine other places are individuals with serious mental illness. The cost to our healthcare system is much more in terms of caring for their physical health conditions, as opposed to their psychiatric healthcare costs. So the physical healthcare costs are much higher in the system. So I think it's a really good question. You know, we've talked today about, you know, psychiatric outcomes, criminal justice outcomes, but health outcomes is really important. And that statistic always sort of gets me about how our clients tend to die 25 years younger than others without serious mental illness. And there's a lot of potential on the team in the model, especially in the nursing staff, I think. So one thought is really around hiring too. We hire psychiatrists, psychiatric nurse practitioners. We really try to hire people who are medically quite competent as well. The nurses, we really have them focus not just on giving the injections, but really connecting people to primary care. I will say it's our FACT clients who sometimes haven't seen a doctor or had a physical in 10 years, really start from scratch kind of in terms of their physical health. And focusing on the basics, even if it's about helping someone quit smoking or engage in metabolic monitoring. I think there's a lot of opportunity.
Yeah, great, thank you. Yeah, thinking that, we do know that, poor physical health really contributes to exacerbating mental health. And so, it's that holistic approach. I appreciate that. Thank you. So what type of oversight is there for FACT teams? Is there any sort of regulation or oversight to FACT teams?
I can start just in New York. So FACT teams are licensed by the New York State Office of Mental Health. So there's oversight there in terms of our operating certificates. And because we receive the deficit funding through the New York City Department of Mental Health and Hygiene, we are also under the city oversight. And so we work very closely with the city that provides a specific scope of services for FACT and also provides technical assistance to us. But I'll let Gary say a little bit more about FACT and Fidelity as well.
Yeah, and I thanks, Jessica. And I think my answer was it probably varies state by state. So here in North Carolina, for example, FACT is not recognized independently of ACT. So there are ACT fidelity standards and ACT monitoring, but not so with FACT, even though we probably have some teams here in North Carolina, and I think this is right, who say they're FACT teams, but they're not recognized that way. So, without clear fidelity standards and the amount of research as there is for ACT that proves that if you do this model you're going to get these results, we'll probably stay a little bit behind with respect to monitoring FACT and FACT fidelity and outcomes. But you're hearing the perspective from two states, and it could be different in other states.
Okay, thank you. Yeah, because one of the questions sort of in relationship to that was sort of how to ensure FACT fidelity. But as you sort of indicated that it's not as clear as the, ACT team fidelity and criterion and the oversight and the sort of the regulations around that. So it's really, ensuring that people are following an ACT model, at a minimum, because the FACT add-on it varies from area to area. So, okay. So both in practice, Dr. Klaver and Dr. Cuddyback, and maybe some of the research you've looked at, what do you see are some of the common mistakes FACT programs make in the execution of services?
That is a good question. And I'm stalling here. Jessica, I hope you have an answer for that one.
Yeah, that's a very good question. I'm trying to think of a good answer. And so I guess where my mind is going is that we've added some enhancements to FACT. I'm just thinking about the risk assessment instruments and the golden thread, running from assessment to service planning to actual service provision. And I think one thing that we're working on is really making sure that these extra assessments that we're doing, so I'm talking about the violence risk assessment, the criminogenic needs, are really making their way, in a meaningful way into the treatment plans and into the service delivery, and that the staff are able to not only do that, but sort of articulate that. And so I don't know if it's exactly a mistake, but I think we've added a lot of things to FACT, and just sort of really integrating them into the practice is something that we're working on.
And now that I had a little extra time, sorry, Jessica, as you think about assertive community treatment, I mean, a couple of things. What happens is the outcomes aren't as good as if you dilute the fidelity of the model. So if you compromise the staff to consumer ratio, or if you don't do 24/7, wraparound services, if you don't do it correctly, then you may not achieve the same outcomes, and then you can say, look, ACT doesn't work. You might think about, even though we don't have the same level of evidence with forensic assertive community treatment, you might think about it that way too. If you're not doing the core components of assertive community treatment first and foremost, even if you add on these extra things, you may not see the outcomes you would hope. I would also say, if you are working in an environment or working with criminal justice partners that expect great reductions in jail days or great reductions in jail costs, but you don't serve folks who have a great number of jail days and a great deal of criminal justice costs, you may not find cost effectiveness or cost reduction. So thinking about who you're going to serve with FACT team and those with the most profound justice involvement are those whom you're likely to make the most impact with. And then I think one other thing, and this is somewhat anecdotal, but in communicating with the criminal justice system, trying to make the case that the mental health system is saving the criminal justice system money by, for example, keeping me out of the jail, right? It's not as if we'll use Rikers, for example. Maybe that's a bad example, but just because I'm out of the jail, for fewer days, it doesn't mean the jail has realized any savings. And the way I think about jails is they're like Field of Dreams, right? You build them and they will come. So maybe I'm not in the jail as often, but somebody else is. So community mental health or FACT team making the argument to a jail saying, look, we saved you $300,000 this year because we reduced jail days among these 30 clients. They don't necessarily see that money. So negotiating around cost sharing and cost savings and resource sharing, it can often be tricky. So that could be a mistake. Now, I personally, professionally haven't seen this happen, but I've heard anecdotes like this. So, and maybe Jessica, those things that I said, if that resonates, or you might react to some of that.
Yeah, no, I think those are really important points, especially in terms of how the systems interact and have different perspectives. And it actually reminds me of one other thing I was thinking about in response to this question is our work with these partner systems, and especially with parole. And I think one thing that we may have underestimated, I guess I'd say, was really the effort at relationship building that I think we needed to put in with some of the partners, and really sitting down at the table with them and hearing their perspective, their role, their job duties, and them to hear kind of what a fact team is, what it can do, what it can't do, and sort of knowing that we're never going to always see something the same way, but that we can have a mutual understanding of each other's perspective. So, I think that sometimes the staff can kind of barrel in with the psychiatric perspective, which is valid, but they're really, we need to have a mutual kind of understanding of each other's roles to truly be partners. And so I think that's something that it just can't be underestimated, that relationship building.
And I would build on that and echo those sentiments. The different missions of the two systems, right? So probation and parole, their mission is to protect public safety. And understanding the language of the criminal justice system and what they need to do and how they need to do it, and understanding to a great extent mental health is working in their world with these justice involved individuals goes a long way to the kind of relationship building and rapport establishing activities that Jessica was describing. So making the mistake of not understanding the dynamics, the language of the justice system, their mission, I think is also a mistake that could be avoided.
Thank you. That was very helpful. Yeah. And you talked about sort of within that, knowing, sort of who you're working with and et cetera. There's been a few questions that sort of reference who you serve. So there are 3 different questions. So I'm going to just sort of present them. So do you work with, and how effective is working with sex offenders on a fact team? And again, with that population, some success with the engagement of treatment and engagement for housing. So is that an exclusion to being able to be on a fact team, or do you have sex offenders, if they meet the other criteria, can be on a fact team?
So I can say, just from my perspective, from where we are, having a sex offense on your record or an active case is not an exclusionary criteria in New York City for being on a fact team. In terms of the treatment, we're going to provide someone with the full array of fact services, regardless of their charge. And I did mention that, the idea of ACT is to be kind of totally holistic, but there are times where we might have an adjunct kind of treatment for someone as part of the treatment plan. And this could be one of those cases where maybe they're receiving fact services, but they're also enrolled in a program that can really address their specific needs around maybe a sex offense that occurred. So with housing, housing is hard enough for our client population. But certainly if someone has a sexual offense history, they may have some kind of restrictions around their housing. And so the team, has a housing specialist who has some expertise in this. And again, we will assist the person with housing. And it's one of our competencies to sort of be aware of all of the options for all types of clients with all types of legal histories. I'm also thinking of arson, in this context where it's a little bit harder to house someone. But there are resources available, and so we do connect people with those. Gary, I don't know if you want to add anything onto that.
Boy, no, I thought that was terrific, and that adds an even more difficult layer onto an already complex case, and another, treatment system. An individual who's experiencing homeless and mental illness, who has to stay registered as a sex offender and check in with maybe a specialized probation officer, just adds a whole different layer of complexity of supervision on the part of the criminal justice system, And it seems like coordination and collaboration between a fact team and that probation officer. So that is a difficult one. And, you know, the restrictions around, as Jessica mentioned, um, housing and maybe even treatment. Maybe, you know, if an individual, depending on the offense, can't be in near a treatment facility where both children and adults are being treated, so it may really limit treatment options as well. So um, lots of complexities when you add on those particular offenses.
Okay, thank you. So again, looking at sort of clientele, knowing that fact teams are voluntary, do you work or how do you work with those that may be mandated? And do you get folks that have been mandated to a fact team or mandated for services, and then fact team being one of the possible services? So what about sort of that mandated person that's been mandated?
Yeah, I can start. We do have our fact clients have uh, an assortment of different mandates over their heads. So, you know, one of the most common ones is an assisted outpatient treatment order. So this often happens as a part of a discharge from a hospital or correctional facility. It's sort of part of the plan. This is involuntary outpatient treatment, so they're mandated to us, and we're mandated to them. And so I think there's a way you can sort of approach it with the client. You know, it's sort of triangulation that I think our very clinically skilled staff are able to do to engage people who do have that mandate. That's sort of, I think, the clearest example. But you know, parole is, you know, has its mandates. Probation has mandates. If people are in mental health court, you know, they're under mandates. Alternative to incarceration mandates. So I think it's truly a clinical skill to work with a mandated population, and an expertise that fact staff have developed. And we see mandated clients, you know, across all of our behavioral health services. I think we have over 100 clients on AOT orders just in our ACT teams, and um, so I think it's sort of how you clinically approach that mandate with the client that makes all the difference, in my opinion.
And I have nothing to add to that.
Thank you. So on a fact team, do you ever mix your clients that some are part of traditional act and criminal justice involved? Do you ever mix the populations, or are they all specifically involved in criminal justice?
And briefly, I would say in the literature that I reviewed, there were both. There were some teams that were purely taking referrals or serving only justice involved, and others with a mix. Um, for those teams that served a mix, there was almost an element of don't mix them, because those who aren't in justice involved may learn some behaviors that might lead them to justice involvement. So it wasn't always a good idea, but that purely is anecdotal as well. So there's no hard evidence, of course, that if you mix these populations, the non-justice involved population will become justice involved. I will say one other thing. Um, I think in looking at the literature and talking to teams, I mean, focusing and um, just on those who are justice involved helps you get better at serving uh, that population quicker than I think if maybe you have a mixed caseload. But let me speak, or let me turn it over to Jessica for her thoughts about that too.
Yeah, I'm just thinking, you know, having ACT teams and fact teams at cases. And I will say that just as a concrete answer, the fact teams, you know, um, people who are referred always have involvement with the criminal legal system. So it's sort of a purer population there. But in my experience, our ACT teams and ACT teams across New York City have a lot of clients who either have a history of criminal legal system involvement or become involved, while they're on the ACT team. So I think that there's a fair amount of that on regular ACT teams in New York City.
Okay. So sort of a follow-up, this person was interested to know that if there is that type of a mix, does it make it hard to balance and switch between treatment types needed for the different client populations?
Yeah, I'm just thinking about that. I think that the regular ACT teams at times might feel like they don't have all the knowledge and expertise maybe that they could have to work with someone who's involved in the criminal legal system. And then on the other hand, fact I always say is like, 90% ACT. So I think they are well equipped to, I think, serve someone who meets the basic ACT admission criteria. And there may be that piece of it where there might be a bit of a skills deficit that they can hopefully get some consultation with. So I can sort of see both, both sides of it.
And I guess if you're going to address some of the criminogenic risks like criminal thinking, antisocial cognition, and there are some practices or evidence-based practices that address those in the general population, like thinking for a change is a CBT-based intervention, reasoning and rehabilitation, moral recognition therapy. So if you're going to address those criminogenic risks, criminal thinking, then you'll need fact staff rather who know those CBT techniques and need to specialize those. So maybe a fact team, everybody gets trained in those, where maybe a team that's mixed, only some folks get trained or one individual gets trained. Jessica, any experience with that?
Yeah, that's a good point. We had planned to really kind of beef up those kinds of interventions, probably
Yeah.
group-based on the fact teams, kind of the risk, need, responsivity, the R&R types of CBT interventions. And we never quite got there. Part of it was the pandemic, but it's the group services that we offer. We do offer some, not a ton on an ACT team. But as it turns out, a lot of the group services we develop were specifically tailored to help people meet their parole conditions. So parole has specific mandates about people being in groups for substance use, a group that might be called anger management. And so we ended up sort of making our group protocols in a way to help people meet those mandates so we didn't have to refer them out. But I think really next level would be kind of introducing those more sophisticated kind of targeted R&R types of groups.
Right, and I'm aware that the team in Rochester, Steve Lamberti's team, Rob Weissman's team, and they had a study funded to look at adding, I forget which one of the interventions it was, to address these criminogenic risks. But if you think about that, and I think this speaks well to your point, Jessica, is that routine fact teams, routine ACT teams aren't doing these criminal justice, criminal thinking interventions that the criminal justice side is doing, thinking for change or R&R or MRT. So almost a gap in what they're addressing versus what community mental health is addressing.
Great, thank you. So one of the participants was interested to know if FACT is considered an evidence-based practice. Apparently, their court system doesn't believe that it's has evidence-based programming and is hesitant to support such a program or to work closely with a fact team. So what can you speak to about evidence-based?
Gary, I'll let you start this one.
Take a shot. I mean, it depends on definition of evidence-based, and like a purist research definition would be 2 or more well-conducted randomized controlled trials done by different groups, different PIs, for example, that clearly show fact would be superior to usual care or whatever it's being compared to. We don't currently have that like we do for assertive community treatment. There's one randomized controlled trial out of California, and then there's the one conducted in Rochester. The difference between the two is the Rochester model did apply these criminogenic CBT interventions. So yeah, I think I would agree. Do we have the evidence, the strong evidence for fact as we do for assertive community treatment? There's quasi-experimental studies and other study designs that all point generally to the picture that fact is effective. You know, for some, under some circumstances, right? Remember when I said, you know, when you think about evidence, for whom, under what circumstances, with what outcomes. So I think there is some evidence that fact can improve criminal justice outcomes. But I would also be hard pressed to make the case that there's an overwhelming amount of rigorous evidence that forensic assertive community treatment improves outcomes across the board. And some of it speaks to our lack of, you know, consistent model, fidelity, measurement of outcomes, target population, right? I think if you look at the literature, you'll see a lot of different populations with respect to their justice involvement being served. Criminal justice outcomes being measured in different ways, or different outcomes. So I think that's generally the state of the knowledge, and it doesn't rise to the level of an evidence-based practice if you use that definition of evidence that I proposed. Jessica, what do you think?
I think I agree with you.
I'm sorry, this is the sign language interpreter just for Dr. Cuddleback. Could you please try to speak up a little bit more when you're answering questions, because the interpreter's having a very hard time hearing you. Thank you.
Yes, I'm so sorry.
Okay, so we've just got time for just a couple more questions. So this always comes up when you talk about cross-system collaboration, working with partners in, you know, the community-based system as well as the criminal justice system. But so what sort of HIPAA protective data can fact teams share with their criminal justice partners, and how best are they sharing this information? And again, might there be any specific statutes or laws that sort of help with this process? So what kind of, and maybe even reframing it to what are some of the barriers people are either experiencing, or how have they overcome sort of the barriers of being able to share information, protected health information and such, among criminal justice partners working in the best interest of the individual?
I think I could start, Gary, but I'm definitely interested in hearing your thoughts on this. So, you know, people who are enrolled in fact services are, you know, receiving psychiatric care. So I think all of the usual HIPAA rules apply. So I think part of it is just, you know, remembering that even though there's so much systems involvement, and maybe 10 people want to know everything that's going on with our clients, you know, we're a mental health treatment provider, and we need to respect our clients in that way. And information sharing basics, you know, involve the client's permission to share whatever information that they would like to share or not share with with someone who may also have a vested interest in what's going on with them on a fact team. There are certainly situations like a court order, or maybe a very, very serious law enforcement kind of situation. I think, a lot of this, I'm thinking again of like parole, who are, a big stakeholder. They want to know what's going on in treatment. And, we really need to, talk with our client about the benefits of us sharing, a limited amount of information with parole, how that might help their parole situation. But again, it's really up to them. So unless we're sort of receiving information from a judge or law enforcement that we have to comply with, we really are kind of engaged in a clinical process around information sharing. And it's really about educating the person about the risks or benefits of sharing their clinical information, and letting them make that choice. And that choice may change over time, which is also okay. That's part of the clinical treatment process. So I feel like that was probably a very clinical response to the question, but Gary, I'm interested to hear your thoughts.
I don't have much more to add. I mean, the issues are tricky. One thing I've seen is difficulty aligning release of information forms. So probation and parole, for example, they might have a release form that they can get their probationers to sign, but it gets to the mental health provider and it doesn't meet their standards. So I think one thing that is particularly teams that are getting ready to start up is try to get the release of information forms aligned so they meet the standards of both the mental health community and the criminal justice agency. I have seen also the criminal justice side sharing information. For example, the local jail sending a roster of folks who are there, each morning to a local managed care organization that then distributes that information, which is public information, to mental health providers. So a fact team might realize, oh, Gary's been in jail again and is getting ready to be released today. Let's try to help with a discharge plan. So I've seen sharing from criminal justice to mental health, but not reciprocal there. So that can happen in some jurisdictions.
Great, thank you. So one of our participants was interested to know, so how do people sort of find a fact team? How do they sort of get referred or engaged? And can a family member play a role in helping a loved one that maybe has serious mental illnesses and has been in and out of jail know how to help their loved one maybe come to the attention of a possible fact team?
Yeah, this is a great question because I think there are, as I mentioned, over 100 ACT teams in New York, over 60 of them in the state, or sorry, in the city, 5 are fact teams, but we know there's more people who need these services, and it's like, how do we connect them with these services? And I know in the beginning of my talk, I mentioned that in New York City, particularly, there's a single point of access. So I know this works differently in different places, but here anyway, the person has to be referred to this single point of access in the city, and they sort of assess the person's situation and then may assign them to an ACT team. So we're on the receiving end of those assignments. A lot of times it's a hospital or some kind of institution, but it can and increasingly is, I think, maybe a shelter or a housing provider or even a family member. With that said, I mean, these systems are, I know people find them difficult and complicated to navigate, including family members. So I think getting the awareness out too is helpful. But in New York, that's how it works. But I do imagine it works differently maybe much differently in other jurisdictions.
Yeah, so that sort of another person had asked, sort of in line with that, sort of how do I find out, if we have a fact team in our community, and since they are perhaps very different from state to state, it sounds like it might be useful to say, inquire at your mental health, community mental health center, or the hospital if they know if the community has a fact team. So I guess it's, whether it's a family member, but even others in the community that might be service providers, sort of gaining awareness as to, does our community have fact teams? And so trying to help get that awareness. Okay, and just one last question, because you talk about people getting referred and directed into fact teams. People can stay on fact teams for life, just like they can stay on ACT teams. But do you ever discharge someone from a fact team, and is there a criteria? And upon discharge, is it a step down to an ACT or to some other lower level of care?
So this is a great question. I can answer just from the New York State regulations, and Gary, you may know different from North Carolina or more nationally. So we have a set of discharge criteria for FACT that is actually the same as for ACT. And it includes things like, if someone passes away, if they go into a nursing home setting, if they're incarcerated, missing, hospitalized for maybe more than 3 months, we have to consider discharge. If the client is requesting discharge, that's also a situation where we would consider it, depending on the circumstances. And then, of course, there are the graduations, which we do see, and we celebrate on our FACT teams. And the step down from FACT, to answer that part, I will say in practice is most often to a clinic setting. So setting someone up with a clinic, and also, if possible, some kind of case management service in addition to that, just to kind of help the transition. So we don't see a lot of FACT to ACT type step downs. The step down is more likely to a clinic setting. So, Gary, I don't know if you know anything else just from a broader perspective.
Now, the only other thing I would add would be folks who are mandated or who are participating in FACT because of probation requirements. Once probation ends and FACT then all of a sudden becomes voluntary, we see some folks choose to discontinue services at that point, which is a little different issue than transition. But other than that, I don't have anything to add to your answer.
Okay, thank you. So that's all the time we have today, but I'd like to leave you with one comment from one of our participants. That this person says, I'm a peer support in Fairbanks, Alaska, and I look forward to the day that we are where you're at. So you really added a lot of value, both Dr. Claver and Dr. Cuddyback. The information was extremely invaluable, so we want to thank you for your presentation. And we want to thank everybody that was attending today. Again, if we didn't get to your question, you'll have these slides available. It will have their contact information, so you could certainly reach out. But we hope to see you at the future sessions of the Gain Center's virtual learning community on early diversion. So have a wonderful afternoon and take good care of yourself.